I'm Julie Vose from the University of Nebraska Medical Center hosting the lectureship today. And it's my pleasure to have two of our faculty here to discuss trying to build and advance the survivorship program. So first, Dr. Rachael Schmidt, who's an advanced oncology certified nurse practitioner and program director for the cancer survivorship, cancer risk and prevention programs at Nebraska Medicine. Rachael received her doctorate degree in nursing practice from UNMC and has led the program development for our survivorship program, strategic planning, clinical operations now for several years. And she's going to be joined today by Dr. Laura Tenner, who's a board certified medical oncologist with a focus on gastrointestinal tumors. And she serves as the medical director for our cancer survivorship program here at the Buffett Cancer Center. Her research interests include using principles of ethics to help inform health services research, cancer survivorship care, delivery, and health policy. So we're going to start out with Rachael to give some of the background, and then Dr. Tenner will take over. Thank you.
All right. Thank you, Dr. Vose. So today we are going to be talking about advancing survivorship care through program development. I have one disclosure with my research with Daiichi Sankyo and Pac Health, and then Dr. Tenner does not have anything. Today's objectives are reviewing the models of survivorship care, exploring some special areas of survivorship care populations and where survivorship can expand to, and then briefly going over the financial support of a survivorship program. So to start out with all talks, I always like giving a brief overview of what cancer or who a cancer survivor is, and the definition from the American Cancer Society as well as NCI and their Office of Cancer Survivorship states that anybody who has a diagnosis of cancer, so the moment of diagnosis through the remainder of their life, is considered a cancer survivor. I always like to include this picture of me and my mom. My mom is a thyroid cancer survivor back in 2013, and she has gone through a lot of what many cancer survivors do with treatment, and then also a recurrence a year later, and then several other scares of recurrence. But she is one person or one cancer survivor who doesn't always like being called a cancer survivor. So this term doesn't resonate with everyone. Some survivors think that if they didn't go through chemotherapy and lose their hair, they're not considered a cancer survivor. But technically, everyone who has a history or a diagnosis of cancer is considered one. So when we look at cancer survivorship, there are these four main components of care. And prevention is when we are screening for new cancers or promoting lifestyle behaviors to reduce the risk for new cancers. Surveillance really looks at screening for their cancer diagnosis. Intervention is trying to help with any late and long-term effects that may have occurred during treatment or may occur in the future. And then coordination of care might be the most important one, and that is focusing on providing that coordination of care, or we like to use treatment summaries to help bridge the gaps between oncology, primary care providers, and patients. So we're going to dive a little bit deeper into all of those coming up. But why are we focusing so much on cancer survivorship? Well, we know that there is an emphasis on developing survivorship programs because there is an increased number of cancer survivors. As you can see from that large graph, back in 1975, we were at 3.7 million cancer survivors, and by 2040, we are expected to have over 26 million. And so the number of new cases of cancer continues to increase each year despite declining incidence rates, and that's a result of population growth and aging. And so with this, we know many people are living years beyond their disease. 69% of people living today were diagnosed over 5 years ago. So trying to focus a lot of this new phase of care onto patients who are out of active treatment is important, because we know that a lot of them are experiencing a decreased quality of life, whether that's for physical problems. About 1 in 4 cancer survivors state that they have those, or emotional problems, where 1 in 10 cancer survivors complain of that. So we're going to dive in to the different types of care models out there. We know that survivorship is relatively still a new phase of care, and across the country, it's been implemented in many different ways. So bear with me when we go over these because they're all different, but I think there's at least 6 different types, but when I've talked to different programs across the country, everyone's doing it differently. There's the oncology specialist type where there's that continuity of care that's really important to both the patient and the oncologist, but there's not a lot of time that's able to be spent on the late and long-term effects or wellness. There's the multidisciplinary clinics where every patient comes and sees like 4 different specialists, whether it's somebody who's specializing in survivorship care or nutrition, PT, OT. They have a lot of experience in the late and long-term effects, but it's very resource intensive. It's not needed by all survivors. There's the disease-specific survivorship clinics that are out there. This is where oncology keeps their disease, and then they may have like an APP that might be dedicated to breast cancer survivorship. So it's very limited to larger populations of cancer survivors. It's easier to pilot these types of services, but then we're kind of missing specialized or, the smaller groups of survivors. And then there's the general survivorship clinic. So this clinic may provide survivorship services for any type of cancer survivor. It's one of the financially more efficient groups out there or clinics out there, but it is difficult to have expertise across all survivor groups. And then a consultative survivorship clinic is usually where it's just a one-time follow-up, and then they transition back to either oncology or primary care or both. It's, again, just a one-time visit, so it may not fit the needs of the cancer survivor population. It requires a billing provider. It's limited time with the patient. And then the last one is that community shared care with primary care. The focus is always on wellness and comorbid conditions. But again, primary care doesn't always know the guidelines or all the knowledge related to late and long-term effects. And some of the roles between oncology and primary care might be blurred. And so nobody may not know who's doing what. Again, this one is a little bit more difficult too, because as we all know, our time is limited. And so oncology usually has 20 minutes with the patient, and so does primary care, and they're both trying to cover a lot of ground. So not one survivorship model is perfect. And I really think that moving forward, survivorship care is going to get a lot, or is going to need to be more personalized. So when we start talking about that, not one, like for care for cancer survivors is not one size fits all. It needs to be personalized. We know that we have this pending crisis where there's shortages in oncologists and primary care providers, nurses, and then we have this increase in the survivorship population. So when we tailor the approach to needs of the patient, we can create a system that matches their level of care. So some survivors are really doing great, and they might not need a lot of care moving forward. So we would put those in the low risk population. They can really do a lot of self-management and transition back to their primary care, as well as like follow with oncology for their surveillance visits. But then we have more survivors who have a moderate or high risk of recurrence. They might have late effects that are already starting to present, or just at high risk for some of those late effects. And they should possibly be followed by a multidisciplinary team or a survivorship clinic that can help, kind of delineate what referrals need to be done. If there's specific guidelines to their care, go over those and do enhanced screening. So with that, I will share what we do here at Nebraska Medicine. So at our program at Nebraska Medicine, we have a mixed model example. We do have a general survivorship clinic that has any patient, anytime that they were diagnosed, like if they were diagnosed 5 years ago, 10 years ago, they can come in for a visit. We then determine our follow-up with these patients based on what their needs are. So it could just be a one-time visit with patients. It could be that, like, we need to see them 2 or 3 times to kind of address some of their other cancer needs. They may have depression, anxiety that we need to work through, or discussing hot flashes, sexual dysfunction, any of the above. And so we really tailor the follow-up visits to what the patient needs. And then we do have a couple groups that really wanted to follow their survivors, and those are the thyroid and our gyn-onc patients. They feel like they have a very specialized group, and as in thyroid, most of their late and long-term effects are based in the endocrine world, so they are the right people that should be following some of those things moving forward. With our allogeneic stem cell transplant patients, we developed more of a long-term follow-up clinic for this group in survivorship, because we know that they are at high risk for a lot of late and long-term effects. So we follow them at least once a year for the rest of their lives. And then in our adult survivors of childhood cancer clinic, this is more of a transition clinic from the pediatric clinic over to adult care. And because they were treated as a adolescent or a child, they have a lot of late and long-term effects that may present much earlier than they would in adults. And so we follow these people or these patients for the rest of their lives as well. So one thing that I do like to make clear is that we do find value in survivorship care plans. We fill them out for all of our patients, because this is how we know which recommendations we need to move forward with for the patients. So we need to know what their treatment was, chemo, surgery, radiation, any endocrine therapy, etc. And then that informs our follow-up plan. So survivorship care plans are valuable still, especially when you have a dedicated survivorship visit and a survivorship clinic that may not be part of their initial oncology team. So all of these patients are new to us. And so it is important to gather this information and share it with primary care, because we act as a bridge for them too. We call all primary care providers, we send these survivorship care plans to them, and then give them instructions on what the timing for different follow-up tests moving forward. So I feel like a good way to utilize survivorship care plans to improve coordination of care is having that clean communication between the oncology group and the primary care provider. So handing that off, reviewing the guidelines, and making sure they're, when we give primary care this information in a care plan, it's very specific, because if you look at guidelines, they say, consider doing this. And then primary care doesn't know exactly what to do. We don't want to overuse or underuse resources, because we know that can negatively impact the cost and quality of survivorship care. But when they are given specific care plans, we know that it can decrease the ambiguity and increase adherence to care. So we have found that survivorship care plans have been very important in providing the coordination of care, especially in survivorship. So I know a lot of programs across the country define survivorship, or what they do for their survivorship programs, a little differently. So yes, we do have a clinic, a survivorship clinic dedicated to seeing patients, but some programs look at survivorship and they use supportive care services as their survivorship program. So we make referrals to all these groups. We meet with all these groups pretty frequently to evaluate what other things we should be doing. We often partner with genetics very closely, as well as our reproductive endocrinology group, cardio-oncology, which I forgot to put on here. All of those people are very interconnected with survivorship. So now I'm going to transition into some special areas of survivorship to consider if you're looking at expanding your program. And a few high needs areas are oncofertility, which this is the interdisciplinary field that bridges oncology, reproduction, and women's health for the purpose of exploring and expanding options for the reproductive future of cancer patients. We have been doing lots of different pilot projects in this area because we know that this is an area that has a lot of distress for these patients. So we have reviewed the studies, and when you look at somebody who has a cancer diagnosis, if they also have infertility later in life, that is just as distressing as having a cancer diagnosis. So it's basically like 2 hits. So these people have reduced quality of life if their infertility risk is not discussed up front. In some of the studies, if you look at it, there are patients that may choose a less effective treatment strategy in order to avoid or reduce the risk of infertility. So we want to make sure that we are addressing this in all patients. We want to make sure long-term quality of life is unaffected, or we can, at least help try to prevent some unresolved grief and depression because this wasn't talked about. So every patient in the guidelines, they state that every patient less than 45 should be informed of their risk. So this is a really great pathway. If you look on the Oncofertility Consortium, they have lots of resources there and pathways there that describe who should be informed of their risk. Basically, everyone should. So once you're diagnosed with cancer, you come up with a treatment plan. We should always be assessing the fertility risk and then discussing that with them. Anybody who is worried about it should definitely have a referral to a reproductive endocrinologist to talk about fertility preservation options. Anybody who is ambivalent or unsure should also be referred. But those that say that they do not want to be referred, they still need to be informed of their risk. So a couple best practices that could be implemented within a survivorship program is to have somebody dedicated up front to discuss the infertility risk and fertility preservation with all patients between 15 to 45. Refer those patients that are interested or ambivalent. Address the fertility preservation before treatment starts. Document it, which is something that we're trying to improve every day. Documenting that discussion, and then be able to answer some basic questions on the impact of cancer treatment on their fertility risk. And then refer to psychosocial providers if there's any distress. So this is one way to help improve survivorship long-term. Another group that we should be looking at that is also high needs is the adult survivors of childhood cancer. So with this group, we know that cancer therapies continue to improve and the population of childhood cancer survivors continues to increase. Because they're diagnosed at a young age, their bodies are still developing, their organs were still developing when they were receiving treatment. And so they can see a lot of these long-term health issues happen much earlier, sometimes 20 years earlier than it would in an adult patient. So when they're going through treatment and then also transitioning or getting older, they're actually going through 2 different types of transition, which can be really hard for the patients and the family. The first is because they're going from acute care to long-term follow-up. If they have to go to a different institution, the way people are doing things might be different. The focus shifts from surveillance over to late effect screenings and health promotion. And then there might be some mixed emotions, not seeing staff as frequently because we're decreasing that time interval. And then there's also going from pediatric care to adult care. So they're transitioning from a familiar setting to an unfamiliar setting with all new providers. We're really trying to focus on prepping the survivor rather than the family member to start taking control of their care, and that can be a difficult transition. And these adolescents are just aging out of the healthcare system. So they want to follow with the oncologist, that saved their life years and years ago, but now they are 18 or 19 and that institution may not be able to follow them anymore. So a lot of areas of improvement, when you look at the literature, is we know that this population may have a deficit of health-related knowledge. They might not be as engaged in health promotion or screening practices. If you think about it, when these patients transition, they're in their early 20s most of the time. They might be going through college. They might feel fine. They may become lost to follow-up because they are asymptomatic. They don't think that they need to be followed anymore, but they're also incredibly high risk for these late and long-term effects. So we developed this Adult Survivors of Childhood Cancer Clinic, where basically Nebraska Medicine, our survivorship clinic, will take patients from our children's hospital, our Nebraska Medicine pediatric bone marrow transplant clinic, as well as any patients who self-refer because they moved and they need they wanted to get established with oncology, but their cancer was when they were a child. So we see all of these patients. We really try to focus on emphasizing risk-based screening and health promotion, reinforcing the importance of follow-up for asymptomatic survivors, creating that plan and reasoning of why we're doing certain things, and just re-educating the patient and a lot of the time the parents of this is what needs to be done should be done moving forward, and is really like a lifelong screening plan. And then continuing to provide up-to-date resources for the survivors as they mature. One of the big things is talking about oncofertility, like we mentioned previously, but a lot of these patients didn't have that discussion back then. So trying to do this on the back end, should they start freezing eggs now, even though they're not quite ready for a family, because as we age, our fertility risk decreases anyways. So we talk about a lot of that information. And then this is also a great clinic to facilitate survivorship research because they are captured long-term. So our last group of high needs patients that are great for expanding survivorship programs is our post-allogeneic transplant survivors. So this group, we continue to increase the number of transplant survivors in the US. We have more than tripled since 2010 by the time 2030 comes around, but we know that there's lots of chronic health issues that happen after transplant. About 40% of transplant survivors will develop a severe health condition 15 years after transplant. And then we know that the life expectancy and quality of life of transplant survivors is less than the normal population. So this is a busy slide. It goes over all of the potential adverse effects that can happen after transplant, and I'm probably missing a number of them as well, but with the type of treatment that they had. So we really review all of these. We have very specific guidelines that we follow for these patients. And this is something that as a group between oncology, we decided this is too much to be done during the oncology visits. So we have utilized our survivorship clinic to improve quality of life of our transplant patients by adding in yearly visits with survivorship to address these issues, such as fatigue and sleep and nutrition, all of the fear of recurrence, depression, anxiety, and screening for secondary cancers. This allows our oncology team to focus on cancer treatment, risk of recurrence, those types of things, as well as patients getting an hour visit at least 1 hour visit every year to address these late and long-term effects in health promotion. So on this next slide, we are going to dive into the financial support for a survivorship program. So we know that the current healthcare environment is characterized by finite budgets and high expectations of good health outcomes. So I know that hopefully I can answer everyone's questions regarding how do you financially support a survivorship program, but we're going to take a look at how we developed ours and then some options for everyone else. So our program started back in 2016. As everyone remembers, the Commission on Cancer was really pushing for survivorship programs and meeting a certain number of care plans needing to be handed out. So that's when I was hired to help start this program. And then in 2017, we decided, instead of focusing so much on delivering these survivorship care plans, we should have a more comprehensive visit with patients. And so we started having hour-long visits with a lot of our breast cancer patients and bone marrow transplant patients, because those were where our faculty was most interested or invested in. And then as more staff was interested in this, we just kept adding different groups. In 2018, we got approached by our neighboring children's hospital to pilot an adult survivors of childhood cancer transition clinic. And so that's when we launched that. And then in 2019, we really needed to hire a second APP. By then, we were able to launch that long-term follow-up clinic for our bone marrow transplant patients. We decided to have more resources or events for our survivor patients. And so we created a survivorship week. And then in 2020, it was COVID. So we had a little bit more or less patients being seen, more time trying to figure out quality improvement. And so we dove into getting educated on oncofertility, expanding our telehealth services, and as well as our lymphedema, trying to do some assessments up front and improve quality improvement there. In 2021, we developed a survivorship conference virtually. We were able to hire a full-time scheduler as well as a nurse case manager. And then we created the program director position for myself. And then in 2022, we hired another APP. We increased our clinics to include long-term follow-up for breast patients. As we know, like, breast cancer patients want a lot of education. They have a lot of quality of life issues. We felt it was easier for survivorship to take on some of those longer high needs patients than oncology doing that. And then in 2023, we had a hybrid survivorship conference with over 300 attendees that targeted patients as well as providers to increase education. And then we launched our disease-focused team for survivorship research, which Dr. Tenner will talk about in a little bit. But one of the most important things in starting a survivorship program was our stakeholder involvement. So I was very lucky to be surrounded by a lot of physician champions, including Dr. Vose, who wanted this to happen and made this happen. And then we were able to have a medical director involved as well. And so Dr. Tenner is in the position now, and she's able to give a survivorship report at every monthly division meeting, which just keeps survivorship up front for all of our providers in oncology. And then with our administrative leadership, I meet with them regularly, at least once a month, to discuss strategic planning. Where can we move next? What do budgets look like? Things, and a lot of operations. And then in the cancer committee meeting, having myself be a key member there, I was able to kind of show everyone how survivorship can contribute to quality improvement initiatives. In the cancer committee, there's lots of different standards that we have to meet. And for quality improvement over the last several years, survivorship has contributed to almost every year. And then lastly, I've been involved closely with marketing and outreach to develop things surrounding social media, articles in some magazines that go out to our patients, mailers, flyers, etc. So business plan wise, when we look at survivorship, a lot of people are like, how do you make this financially stable? One thing that you can do, if you have a provider in the clinic, looking at how it can be reimbursed. So professional fees, facility fees, Can downstream revenue be part of your analysis or your pro forma when putting together a strategic plan for this type of program? Those are all things that we've used to help fund this program. Looking at, does this program offload oncologists to be able to see new visits in a more timely manner? Are APPs being utilized in independent clinics? So that's something that we are very proud of at our institution, is that in survivorship, we are one of the biggest group of APPs that has independent ran clinics. And then other programs across the country use grant funding to help support this, or philanthropy. I think that when you do a business plan, there's a lot of other things that drive value. So in addition to like the downstream revenue, like is there increased patient satisfaction, MD satisfaction? Is there any cost avoidance that can be done? Are we adhering to guidelines better, or meeting some of those metrics? Are we increasing research numbers? Are we keeping people inside the institution because we're referring to different providers? So I think all of that is should be attributed to return on investment when you develop a survivorship program. So the infrastructure that we have within our program, like I mentioned in our timeline of how it was developed, is that we do have a scheduler. We have a nurse or a patient navigator that helps with all of these patients. She helps create our survivorship care plans. So that way the advanced practice providers can be very dedicated on what guidelines they need to be looking for to determine what follow-up or screenings are needed. And with our advanced practice providers, I feel like we have been very successful because our advanced practice providers are dedicated to survivorship. So this is their role. They aren't also doing, a lot of other things like on the other side of oncology. So they have their own templates, their lists of patients, and it's a very defined role. We are lucky to have a program time for a program director as well as a medical director. So that way we can review guidelines, we can brainstorm ideas of what we need to do next. And then I think a really important resource to be able to utilize is IT, and we try to do that as much as possible. How can we make this easier? Are there ways that we can get patients referred to survivorship and streamline that? So with that, one of the things that I have to tell everyone about if they're interested in starting a survivorship program is just to be aware that there are a lot of resources online to do this. NCCN has a free, I think it's 300 plus pages of guidelines just for survivorship. The Children's Oncology Group has their long-term follow-up guidelines as well. And then the GW Cancer Center has Cancer Survivorship e-learning series for primary care providers. They also have a lot of information on how to develop a survivorship program on your own. ASCO has this, American Cancer Society, the list goes on and on. But there is a lot of free resources out there, in addition to what I just shared on how to start a survivorship program. So next, I'm going to transition this over to Dr. Tenner to talk about cancer survivorship research.
Thanks, Rachel. I wanted to spend probably the last 10 or 15 minutes talking to you a little bit about opportunities. And I think that cancer survivorship research is really going to be the future of kind of where we're headed. And so as you are thinking about creating your programs, or as you're trying to adapt your programs in cancer survivorship, I hope that all of you are really giving some thought to the research focus of it, because we're a pretty young field. Next slide, Rachel. So I want to point out two separate papers, both from 2019. And what I find really interesting is actually, if you look back at the history of cancer survivorship research and cancer survivorship clinics, we're a pretty young field. It wasn't until 1991 where we actually started to see improvements in survivorship rates of cancer. That was the first time where we actually started to see the pendulum swing, and we were doing better in terms of helping people survive through cancer. And it wasn't until 2010 okay, so 13 years ago, that the NCI and the American Cancer Society got together and said, hey, we need cancer survivorship. We need to make this a thing. We need to develop it, and we need to know what we're going to do with all these patients that are living longer. And the information I'm going to present to you is now, about 10 years later from that, in 2019, where they're coming back and they're saying, okay, we started this cancer survivorship thing. How can we improve upon it? And they're trying to identify evidence gaps and research priorities. We're a very young field. Cancer survivorship is extremely young. And to be quite frank, none of us know exactly how to do it, which is why when you saw in Rachel's presentation, there's 8 to 10 different ways of designing your cancer survivorship research program, and which way is best and what way best serves the patients. And so those are all things we're still trying to answer. And so as we build these programs, we would be doing ourselves a disservice if we're not incorporating research opportunities to be able to collect some of this data and learn from what we're doing so that we can continuously improve our care for cancer survivorship patients. So if we look at this 2019 National Cancer Institute survivorship workshop, where they pretty much got together to identify evidence gaps and research priorities pertaining to cancer survivorship, they looked at specific areas, and those included the need to understand and address disparities among cancer survivors. And I think that was the big one. We have this idea that, one size fits all for cancer survivorship. And I think that nothing could be far from the truth. We need to start looking at specific populations and how we can better provide those services to those particular populations. They also looked at conducting longitudinal studies as well as long-term follow-up studies. So really kind of trying to see how we're doing in survivorship over the long run, and even going beyond those 5 years, right? I mean, we used to be 5 years the mark for cure. If we get someone to 5 years, we cured them. Well, now we're looking at much longer than that. I mean, we're even treating with endocrine therapies and breast cancer up to 15 years beyond, right? So our studies need to be looking at these longer term outcomes. And then leveraging existing data. There is so much information gets put into our electronic medical record systems that we can't then pull back out. So when we're developing these programs and these systems, we need to design these programs so that we can actually then access this information so that we can improve upon our systems. And of course, incorporating implementation science strategies to translate findings into practice. So when we find a program or a system that works better, how do we then implement that across all of our cancer survivorship programs? Or how do we quickly get that up and running so that we're not waiting another decade before we have changes? Next slide. So gaps in knowledge included things like understanding recurrence risk in the different subgroups in cancer populations. And these groups were age, race, ethnicity, immigration status, socioeconomic status, sexual identity, and rurality. And I mention rurality because that, of course, for Nebraska is a big thing for us with such a large rural population. So there are special populations that we need to really be focusing on and targeting. How do we best deliver cancer care survivorship to these populations? And then, of course, improving on the recruitment of diverse participants to these observational studies or clinical trials, right? We don't do ourselves any good if we want to look at rural populations, but the only people that we put in our studies are from downtown Omaha, right? So we want to make sure that we're recruiting the appropriate people that we want to look at. Many survivors should be getting sex and age-appropriate cancer screenings and general health preventative care, but how this testing should be integrated or prioritized relative to surveillance for recurrence or treatment-related surveillance guidelines is still unknown. So lots of area for growth and research in this field. Next slide. In this workshop, they highlighted some topics for study, continuing to improve our surveillance, continuing to manage long-term and late-term effects, which we have been managing our physical effects from the beginning. That's pretty much a standard. But the psychosocial effects now are starting to become a little bit more of a focus. That's kind of a new area for which we're really trying to delve into, because we were recognizing if we're not managing the whole person, we are not doing a good job in our cancer survivorship care. Health promotion, care coordination, and of course, financial impact, which has become much more popular in the last decade or so. Next slide. So they talked about strategies and approaches to try and engage implementation science. And these really focus on expanding data resources. We have to do a better job of managing our big data, of being able to leveraging big data, being able to look at the patients that we have coming in and pull that information back out. So as you're looking at setting up these systems, make sure you have an EMR system. Make sure, as Rachael said, you want to have those EMR and analytics and staff working with you from the get-go, because there's easy ways to pull data and there are hard ways. And if you're just trying to read free text, that's the hardest way. You want to have discrete points that you can pull data from so you can continuously improve your system. Exploring novel data linkages, building data infrastructures, establishing common data elements. All of these are important. Patient-reported outcome measures, or PROs, are probably the biggest hot topic for survivorship, because we don't know how to do that well yet. What we have done in the past with patient-reported outcome measures is looking at symptom assessments of patients, but in survivorship, it's a little bit different. We're not on active treatment necessarily, so we're needing to look at more like needs assessments with patient-reported outcomes. So that's kind of the next avenue we're going to be using and trying to leverage our electronic medical record systems to help us manage patients in a more appropriate way, and developing novel analytic methods. Next slide. The second paper I'd like to draw your attention to was also from 2019, and this is a survivorship care framework. So it's implications, for clinical care and research and policy. Next slide. What they really tried to do was develop this quality framework, which outlines all the things when you're developing a survivorship program that you really need to be thinking about, and all the areas in which we need to try and be improving upon our cancer care delivery. So you can see in the red block, this is kind of our traditional survivorship strategy, which is just surveillance and management of physical effects and prevention for new cancers, right? So that's really all we've kind of been thinking of since the beginning of survivorship, is how do we make sure their cancer doesn't come back and they don't get new cancers. But when you look at this whole framework, we're starting to recognize that there's so much more to cancer survivorship that we really need to be focusing on. And it has to be things like health promotion and disease prevention. It doesn't do us any good if we're just surveillancing for new cancers and trying to find them. We need to try and prevent new cancers from happening. And so we're learning more and more about patients with genetic predispositions to cancers and how we can prevent them from developing new cancers. We're learning about health promotion strategies to try and prevent cancers from actually occurring, as opposed to just trying to put band-aids on them after the cancers recur. And of course, surveillance and management psychosocial events, right? We're starting to look at the psychosocial issues from having cancer, living after cancer, right? All of the mental health issues that play into that. How do you get back into the workforce? How do you reconnect with your family and friends and loved ones after going through something so traumatic? And so that all plays into making sure that these individuals become members of the society again, members of the community, and are back to functional and living those years that they have gotten from this cancer survivorship to their fullest extent. And then, of course, surveillance and management of chronic medical conditions. We get so focused on the cancer that we forget about all of the other things that may be implicating and causing issues in terms of secondary cancers and things like diabetes and heart issues and those kind of things. So making sure that we really tie in our primary care groups into our survivorship plans, making sure that our primary care groups feel like they're on the front lines with us, so that we're not letting some of these other comorbidities go to the wayside, causing future problems for these patients in the long run. So you can see there's all these individual factors. There's also interpersonal factors, getting people back into the workforce, getting them back into their communities, getting them back to being active and playing a role in their life again. And then organizational factors and community factors. And then finally, policy factors. And I think policy factors have been one of those things that we have not really noticed the impact of until COVID happened. And it is amazing how, if you want to get something done, you just have to make sure it gets paid for, right? I mean, we had the capability of telehealth, over a decade before COVID happened, and the usage of that was almost nil. Now, when COVID becomes a thing, and we now have a way to pay for telehealth visits, it becomes kind of the main avenue in which people were actually caring for patients during that time. I think you would find similar things if you were looking at, for example, nutrition, right? We don't have nutrition for cancer patients paid for in an effective way unless they're diabetics. And if we could get those insurance companies or payers to pay for some of those things, it would be amazing how much more access we could get patients to it. And we do that through policy. And so policy actually does play a huge issue in our day-to-day practice and treatment of patients, and as physicians and as physician extenders, and providers of patients, we should be aware and active in that role for that. And to factor all these things in and make sure we're doing the best care we can for patients, the outcomes that we should be measuring are things like health-related quality of life function, emergency service and hospitalization usage, things like cost for patients in their survivorship realm, and of course, mortality. And I think the main focuses have been only on things like quality of life, health-related issues, but not like how much are these people using our emergency rooms and hospitals after they complete their cancer treatments. What is the cost effect of them on their life and getting back into the role in their lives and with their families and things like that. So these are all things to look at. Next slide. So when they looked at this quality survivorship framework, most commonly proposed measures were physical and psychosocial, but things that were like care coordination, healthcare delivery structures, those were rare. We're not doing the research we need to do on those areas. And so there was a stress and a focus on trying to get people to focus on the research on those areas. Outcomes such as cost, mortality, and adverse health care utilization were less frequently measured than health-related quality of life. We need to be measuring across the board all of these outcomes as we're looking at how to improve upon cancer survivorship care. And so opening a program is just not enough. We need to be actually monitoring what we've done and how we can improve upon that so that we can continue to learn and improve our care for cancer survivorship. Next slide. So solutions are trying to get targeted funding announcements for those specific gaps. It's developing new patient-reported measures that may be able to use to actually automate some of the data and automate some of the care for the patient. And it's looking at promotion of well-designed dissemination and implementation research that can sustain the use of evidence-based strategies in the clinical setting. Next slide. The benefits to having a designated survivorship clinic is that it has this focus of pooled patients that you can recruit for this research, or that you can pull from your electronic medical records to get ideas of patients that could participate and to write grants for. It allows easier collection of EMR data. It allows easier implementation of patient-reported outcome measures, and even you can target select populations because you have this kind of focus of just cancer survivors coming into your specific designated clinic. And allows for creation of a disease focus team. And that's what we've done at UNMC. So I'd like to talk to you just one brief slide about that, and then we can open it up for questions. The disease focus team is actually a multidisciplinary group of basic translational, clinical, and population health investigators that all come together and collaborate on a specific cancer area in order to further translation of discoveries through the pipeline towards interventions of clinical trials. It probably is somewhat of a misnomer now because it was first called disease focus because we would focus things on, this is the thoracic, right? This is GI, this is GU, and we could kind of focus it within those realms. When you start to get into things like health services research, so survivorship, prevention, those kind of things, now you have these areas of specific cancer areas of focus that actually span across lots of different types of diseases. So a disease focus team is probably a little bit of a misnomer, but nonetheless, it's kind of the structure with which we have been doing research. And so to fit within that structure, to make opening this as easy as possible, we labeled our disease focus team cancer prevention and control, right? So it is our survivorship team, disease focus team, where we can actually incorporate all the research that's going on and make sure that we are utilizing our resources to their maximum. So we don't want to be opening up clinical trials that are competing against each other and pulling from our patient panels. And we want to make sure that these trials that we are opening are focused and will help us continue to write new grants and improve upon research for these patients. So the benefits to having something like this disease-focused team in survivorship, okay, is to avoid competing studies. It tracks population research, study participant numbers for the NCI. So especially if you're an NCI designated cancer center or comprehensive, these are ways to track your numbers. It collects publications for further funding to compete for research, and builds a community of like-minded researchers that can increase collaborations. And as we know, the grants out there are looking for a lot more collaborative efforts. So I would highly recommend trying to get something like this going with your survivorship program. If you're building this, or if you're in the midst of kind of trying to improve upon your survivorship program, I think we should start having these research areas and focuses. Next slide, Rachel.
Shoot, sorry.
Okay. I think this will just be our references from the rest of the presentation, and we can open ourselves up for questions at this time.
Great talk, guys. Thanks so much. You guys have done a lot of work over the last few years, so thank you. There's a few questions in the chat. I'll read some of which you've kind of already answered, but so there's a question about a specialty clinic or specialty space specifically for AYA survivors, like people diagnosed age 15 to 39. Do you think that's a good model to also add on?
Yeah, so I've been thinking about this for a long time. I think it would be a great use of like a patient navigator to help connect that patient once they're diagnosed. I don't know if they need their own clinic, but they definitely have their own complicated issues that can all be addressed up front. So having a navigator meet with them, give them all the resources up front would be super helpful. But then they still need oncofertility, they still need survivorship. So I don't think they need their own clinic.
Mm-hmm. Yeah, a lot of the issues are the same. It's just like especially focused in that group, a lot more issues maybe.
Right.
Yeah. But if I could just comment briefly, and this goes to my research, this goes to the importance of research, is that I think, you know, we haven't done a lot about how do we get people back into the workforce. And this is really important for this AYA group because they were young getting the cancer, and it's not necessarily getting them back into the workforce, but maybe again, getting into the workforce after having gone through so much and carrying this you know, need for continued surveillance, need for checking in with their healthcare providers and trying to navigate that with a new job and those kind of things. So I think this is an area where we're really trying to look at a lot of research moving through. So as you have these patients in your cancer survivorship programs, it would be great to enroll to some of these maybe prospective trials.
A couple other questions. So is there or should there be a database initially set up when you start this program to gather all the data needed so that down the line you can do research? I think that's kind of a no-brainer. Yes, if you could, right?
Yes.
Yeah, and I would really get your Epic analyst or your Cerner analyst or whatever, you know, program that you have. I would get them involved early on because a lot of times, you know, we know as providers, these are the things that we're going to need, right? These are the questions we're going to ask. This is what we're going to be looking for. But what we may not know is how are the zeros and ones built in the electronic medical record system so that we can appropriately pull those, right? So that we can do quick searches. So we're not having to go through chart after chart after chart to get the information we want, but that can be pulled appropriately. So having those analysts on board from day one of starting your program and developing your record system would be important. And then Rachel has a lot of experience with building note templates and things.
Yes.
Yeah,
A
so
lot.
you can have discrete data so it can be pulled in much easier. Out of all the cancer centers in the nation, what percentage of them currently have this type of survivorship program?
So I'm on the NCCN best practice committee. And when we look at the different survivorship programs, it is all mixed. I wouldn't say that there's any that are identical to us. There might be two that are pretty similar, but I would say about half and half, or I don't know, half and half on disease-based versus just a general survivorship clinic.
Yeah, every place seems to have their own bent on things a little bit, depending on how they can staff it.
Yes.
Should patients, should patients be enrolled into the survivorship program at diagnosis and have a consent form signed? Do you use consent forms?
We do not use consent forms. I would love it if patients got enrolled at diagnosis. That would be amazing, but I think that's a whole process thing that we have to go through. We do try to implement oncofertility on the front end. That's really where survivorship plays a big role up front. But I think in the future, more prehab and stuff like that that would come from survivorship will happen.
Yeah, and we offer research opportunities to patients as those opportunities arise for them. So there isn't a universal consent for it, but instead as opportunities come up, we will reach out to patients to directly consent them. One option for I think some institutions is that they may provide a consent that says, can we reach out to you for research purposes and things like that from the get-go. So that would be an option as well, as opposed to just bringing it up when you see them in the clinic.
Yep. And then are you measuring all of the return on investment metrics, and how difficult are they to measure? Pretty difficult.
Yes, they're super difficult. If you ever have developed a pro forma, not finance wants to use downstream revenue, but it's not always allowed to, get additional positions approved. So yes, we try to measure as much as we can, mostly visits, professional fees, facility fees, downstream revenue, and then it's hard. Dr. Vose, I don't know if you have any other answer for that, but
yeah, no, I agree. It's really hard, but you have to try to point that out to the institution, because otherwise they don't see the benefit sometimes of what we're doing unless you do point those things out. So
right.
Let's see. And then one other one we haven't answered yet. Are these services oncology specific, or do they apply to other areas as well?
We refer across the whole institution. So some of them, like our psychology, is oncology specific, but then psychiatry is their own general psychiatry department. We have some collaborations with different providers that will take oncology patients a little bit more on a fast track, and we've established that between all of the different departments. But yeah, it's all across the institution.
Okay. Well, I think we've answered most of the questions in the chat, unless there's anything else.
Oh, I did see that this one comes up on every presentation that I do. Do you see patients with metastatic disease in your survivorship clinic? We do not. I mean, yes and no. So multiple myeloma, we follow them in our transplant population. So we do see those. There is discussion about doing breast metastatic patients because we know that they live for long periods of time. It just has not been started yet, but it's definitely an interesting population. I know some other survivorship programs do incorporate them.
Yeah, and I would say I think that's where it's heading. So, I think we have been in discussions with our different groups about opening it up to those patients who we know are going to have a long-term survivability, even though they're considered metastatic and on active therapy. And I would highly recommend you considering that for your programs as well. Just like anyone else, they need a survivorship care plan with a guideline to how their survivorship plan is going to be moving into the future. They need primary care incorporated back into their process. Or updated on what they've been through and where the treatments are headed. So I think this is an important aspect to start to implement into survivorship.
And I did see, do you have the bandwidth to reach out to? I have my emails up there, so I think Haley can share it with people too. I talk with a lot of different survivorship programs across the country, and happy to help answer some of anybody else's questions we didn't get to.
All right, guys. Well, thanks for the great discussion today. And I'm sure they'll be happy to send out your emails to whoever to answer some more questions. So
All right.
thanks to APCI for hosting the webinar as well. Thank you.
Thank you.